and stuff. So just a little bit of history coming in. Like I said, nursing's been around for a long time. EMS is coming a long way coming in. And like I said, I think even for future, we may start seeing paramedics making house calls and even nurses doing the same thing to kind of eliminate some of the people going to the ER and blasting the hospitals with all that. So just a little bit of history coming in with that. Just like I told you guys, I wish you could be here with me at the main facility. We've got 3 aircraft sitting in our hangar right now. Maybe down the line when COVID restrictions lift, maybe you guys could make it out. But this is our big hangar. It's Ohio National Guard. We are attached to Don Scott Airport in Columbus, Ohio. And it's just a big hangar where we store all our aircraft and all our maintenance is done on it, and also our MICUs and stuff. So to kind of give you a little bit of example of what that is. We fly a EC-130, and for again, prior to working at MedFlight, I didn't even know what aircraft or all this different things and all this lingo that you guys talk a little bit about. But this is our EC-130, and it kind of has 3 blades on it. It's got a rotor system, and we fly with a pilot, a nurse, and a paramedic. That is the bare minimum staffing we have. And we also have an observer program. I highly, highly suggest when you guys are in the nursing field, if whatever you get into, make sure you research it and understand what you're getting into. I will tell you, we've had people interview here at MedFlight that came in, great candidates, but came in and interviewed and really did not know exactly what we do. I had one nurse tell me she gets airsick when she interviewed, and I thought, well, if you get airsick flying, this is probably not the best place for you. So again, but research it, make sure you ask the people, and I highly suggest you doing an observation day with us. And that goes along with not just MedFlight, but anywhere you work in terms of where you're planning on doing that. Make sure you get a good idea of what you're getting yourself into. We also have MICUs. We have 4 of those, and we also have 9 aircraft based in Ohio. So we're kind of all over the place. I kind of a lot of our out bases is like firehouses, very similar to firehouses. Work 24 on, 48 off. And we also have mixtures of 12-hour and 24-hour shifts. So again, a lot of our bases are what we call remote. They're not attached to the big city. So again, there's a little bit of travel involved working at MedFlight. So again, like I said, it kind of gives you a little bit different example coming in. What we look for in terms of our experience level, we try to make it between 3 and 5 years, probably closer to 5 years experience. And again, where this kind of comes into why we want you to have all these experiences is because you're going to be doing a lot of management. The one thing I will tell you about MedFlight that I really love is the autonomy. You're going to be dealing with patients in the emergency room. You're going to be dealing with patients in procedure labs, and you're going to be dealing with patients that have been in the ICU for many, many, many days coming in. So kind of a different animal in terms of each transport is quite different. With the COVID thing, I'm telling you, we have had so many ventilator issues. With all these COVID patients, they are extremely hard to ventilate, and they are in very, very complex. Well, some of our patients are even what we call in the prone position, actually laying on their stomach to try to help get air into their lungs and try to breathe for them. And those are very, very critical, very sick patients to transport. So that's kind of coming in terms of we want you to have some basic experience to come in before you're comfortable. Once we deem you necessary, we do have you to have a bunch of certifications. Just like my one friend always said, we got a bunch of alphabet soup after our name. We do require a bunch of certifications that come in to MedFlight. And these are all, most of the people don't come in with all these. We will help you get some of these, but trauma, cardiac, neonate, pediatrics, all those certifications are required for us here at MedFlight. And you have to maintain those too. The job interview is a little bit stressful, I'll be honest. We do have a 3 to 5 person panel interview. I don't know if you guys have ever interviewed in a panel. It can be a little bit challenging, a little bit nervousing, because again, you got a lot of different people firing out questions at you on everything. Once you're done with that panel interview, then we kind of bring you on a one-on-one situation with our education team. And that basically kind of goes through a situation. We really want to see how you interact with the people, because you're going to be interacting with physicians, doctors, paramedics, respiratory therapists, all kinds of different things on working at MedFlight. Because basically we're the transport bee. We are the people that are going to get you from one spot to the next. So again, I kind of working really, really hard in terms of clinical situations. If you do deem that we do get a job here at MedFlight, our orientation process works in a couple different ways. It's going to do some classrooms, orientation, and then education on your own. Nobody's a perfect candidate. It's really hard to have experience level in everything. My background is mostly nursing, but I didn't have a lot of field experience. So managing patients in the back of a truck or back of an aircraft or in somebody's backyard or somebody's house or on the side of the road is much different. When you think of nursing, you think of our patients are in a bed in a nice, comfortable environment and treating patients. You might be getting patients now in so many different wide range of areas. It's different, definitely different, challenging. So again, my thought was when I came in, I had the good part of the nursing part, but I had to learn a lot of the paramedic and the basic skills of all that. So again, it's kind of interesting. You do learn a tremendous amount about your different roles in it and stuff. A lot of our nurses are paramedics and kind of go back and get that. So again, it's kind of a two-way process in terms of treatments and stuff. We do maintain you to keep all your certifications. We have a huge tracking system. I will tell you, we do tell people right up front, this is not a 9 to 5 job. There is a lot of continuing education that we are required on a monthly, a quarterly, and a yearly basis. Intubation skills, all kinds of different things you have to require. We really want you to be comfortable and trained at the highest level we can get you to transport, because you're not only calling for a transport, but you're also calling for expertise in the field. And hard to be a perfect, expertise in all fields. I'm not great on OB, I'm not great on pediatrics. That's not my specialty, but I have enough knowledge and treatment that I can get through those. So again, like I said, it's just kind of, we tell people when you come in, it's not just a 9 to 5 job. You're going to be required to do a lot more in terms of learning and stuff. And like I said, right now, we're really pumping ventilator treatment because of our COVID cases. A lot of COVID cases, a lot of ventilator management type issues, especially with our vents. So quarterly skills, I will tell you, this is the kind of the fun part of our job. We do a lot of skills that we don't get to do in the hospital. A lot of our treatment, a lot of our paramedics, treatments or street paramedics will do these. But again, kind of you look at needle decompression if we're going to do a tension pneumothorax. We do rapid sequence inductions. You have to think about our environment. We are definitely, especially on the air medical side of things here at MedFlight, we're going to be putting patients in a confined area in an aircraft. We definitely don't want somebody that's combative or confused or anything like that. So a lot of our patients are getting assessed for a potential rapid sequence induction. For you guys that don't know what that is, basically that's just giving you medications and put you on a ventilator and help you breathe coming in. So it's something we want our nurses and our paramedics to be very, very skilled at. We do pacemakers. We also do cardiac devices. Back when I started, balloon pump was the only cardiac device we have. Now we have ECMO, and we also have Impella devices. So a lot of cardiac devices coming in. That's the fun part about this job, to be honest. If you think it's fun, one day you may be thinking a bunch of cardiac cases, the next day maybe trauma, the next day maybe this, maybe that, maybe a pediatrics, maybe an OB run. So again, when you kind of head out the door here, you're nearly not sure what you're going to have and stuff. And some people like that, some people don't, but then definitely one of the advantage if you like doing that. Some of the other things we do surgical and needle airways. We do ventilator setup, we do CPAP, BiPAP, all kinds of different things. If we have to, we do pericardiocentesis, aspirotomies. These are not things that we're going to choose to do on a regular basis, but they do in our repertoire. There are certain situations we have a certain protocol coming in. It's a little different than your nursing. Again, when you look at nursing, it's kind of, physician order, either has to sign it or circle it or whatever. Ours is what we call a protocol system. So again, if we see this, and that, then we look at our protocol and then kind of list things out and stuff. So I will tell you, when some of our nurses that are not used to that, that is more challenging. No doubt, that is definitely more challenging working off a protocol system. So annual requirements, we do a lot of clinical rotations, 4 hours here, 4 hours there. Basically, we're going to come in with what experience you have and basically get what you need. Not everybody comes in with, I came in with a heavy cardiac. Some people come in with different backgrounds. So again, really basically maintain and get you as clinically comfortable as possible. So I will tell you that again, like I said, and now let's get into a little bit about a typical day, what you're coming in. I will tell you that, a lot of people call this what we call a hero's job. It's nursing. And, it's basically coming in, it's a nursing job. It is very competitive. You do have a lot of people coming in, and I love the autonomy. And to be honest with you, it really works on the 24-hour shifts. We got a lot of nurses that sought after that. Really, we're talking 8 shifts a month is a full-time nurse. So again, you get kind of caught up into not only wanting to do this job, but also wanting to do other things too. So, again, this job requires a lot of extra time, but also time that we can get into other jobs too. The interview process, again, and making sure you're coming in with the experience you needed. And also, I will tell you, this is personality is huge in this. You have to be a team player. You have to be able to handle different personalities. You're going to get people, coming in, are very stressed out, very concerned, generally concerned about the patient. And you have to have kind of a calm demeanor to it. They called you to transport this critically ill patient, and they don't want you freaking out, nervous and scared, and even portraying it. You have to be a good actor here at MedFlight, to be honest. You have to show that you are comfortable in all situations and coming in. And again, hopefully some of you guys listening in, it is a job for you. I really, really think it's a cool thing. It's a cool job for that and stuff. But highly, highly recommend. Again, I'm going to say it. Once you get out in nursing school, actually talk to the crews and also come spend an observation day. That is the best way to explain what we do, how we do it, and everything. So, all right, let's talk a little bit about a day through the eyes of a MedFlight nurse coming in. This is specifically to our rotor wing base coming in. So again, what certifications are needed, some of the objectives you may find with this and stuff, and kind of some of the things you would think. Basically bring it on. You're coming into a helicopter base. A lot of our bases are remote. And what I mean by remote is you're kind of attached to a little bit of a house or a modular, just like a firehouse is. And then you have a hangar and an aircraft, and you come on and everything. So again, with most of our helicopter bases are 24-hour shifts. So when you drive out to that base, you're there for 24 hours. So you better bring all kinds of stuff with you in terms of, you're not busy 24/7. That is kind of an interesting dynamic to our nurses that can come in because, when you work in a hospital or work into a health system, you don't have a lot of downtime, especially when you work in critical care areas. This is about 60% of your time at MedFlight will be downtime. So you have to come in it. A lot of people bring, books and internet stuff and kind of do a lot of different things online and stuff. So it's kind of an interesting dynamic in terms of that, in terms of it. So a typical day, I will tell you the most important thing, and the paramedic and the pilot are all going to tell you is eating, and you got to plan your meals throughout the day. So first things always first, coming in at breakfast. Once you get in your uniform, it's going to be a weather check, safety. I've never been in a job that worries about weather is so much. But again, when you kind of look at what we do, we fly by straight visual. And what I mean by that is the aircraft we have to see where we're going. So there's certain things that we have to worry about, all kinds of stuff that will prevent fog, bad weather, rain, all kinds of things that will affect visibility. So again, we kind of have an idea of what we're coming in to that. So it's kind of like a safety topic. We will go through everything. We will walk through and around the aircraft to make sure that the aircraft is ready for flight coming in. So the first things first, always is get your stuff ready and get your stuff coming in. You will be instructed on everything throughout the day as you meet with your pilot and your paramedic that you're working with for 24 hours. So again, it's a lot of preparation, and then basically you wait and ready to get that transport as you come in. A lot of aviation lingo, you will hear a lot of people talk about different things. I knew nothing about this coming in at MedFlight. I don't know what VFR, IFR, all these different things coming in, but you do learn it. I will tell you too, when you look at MedFlight, you are out in the elements. So you need to dress for what's out there. If it's really hot, you want to make sure you keep yourself hydrated. You're out and about. If it's really cold, you need to make sure. These flight uniforms we carry are the absolute worst at keeping you warm and keeping you cold. One of the first transports I was on here at MedFlight, we had a scene run. It was very, very cold, almost like a day like today. And I just had a small coat and a hat, and I froze my patootie off. So again, it's always preparing for what's the environment. You probably don't think about a lot about that when you guys are working in the hospital, worried about what's going outside because you're in a nice confined environment. But there's some of the things you have to think about. I will tell you nothing worse than, especially at night when you're nice and warm, either in bed or laying around at the base, and going outside when it's really, really cold out. It's just definitely something you definitely want to go through, coming in. So you kind of get your ready to go. You make sure all your things are ready. If you do have a flight on, if you kind of see at the bottom, it's 3 to go, 1 to say no. There's a very, very big push for air medical. I'm sure you guys have heard or have seen that there's some aircraft that have crashed, coming in, and a lot of it, probably 95% of it is pilot error, getting into bad weather. There's a push for it. One thing I will tell you at MedFlight is we really push safety. And that basically means 3 to go, 1 to say no. So if one person is totally uncomfortable with this flight, they will come up and say, hey, you know what, we're not doing it. And then it stops there. So again, it's kind of one of those things of making sure you're paying attention to your environment around you coming in. These are kind of cool. I will tell you some of the differences. When you work in a hospital, you probably don't get these. These are some of the views. This is one of our bases down in McConnellsville, Ohio. I don't know if you guys are familiar with that. It's south of Zanesville. You can kind of see this is the deck coming off of our base. And it's really cool. It's got a grill out there. This is actually Morgan County Airport. For all you guys that, again, I was born a city boy, so I knew there was one county, and that was Franklin County, where I lived. But you learn a lot about different counties and rural areas and stuff. And when you start getting into southern Ohio, it is pretty rural down there. So you have a pretty good drive between hospitals and trauma centers and stuff. So again, you're talking some of the things out there is pretty crazy and stuff. So think of this as just like a house. You have a bedroom, you have your own bathroom, you have a deck, you have a couple different things, and you really get to know your crews. A lot of our bases have the same nurses and the same paramedics and the same pilots that work there. So when you get assigned a base, you really work with the same people all the time. And it's amazing to me, I'll be honest, the stuff you talk about when you're with somebody for 24 hours, you probably learn more about them than what you really want to know. But again, it's a really tight community type thing. That's one thing I will tell you that nurses you probably don't do the best job as. Back when I worked in a hospital, days hates nights, nights hates evenings, evenings hates days. It's one of those things if you kind of, there's a lot of friction between some of that, but here it's not that way. And I kind of understand the camaraderie that you have, like the fire departments and the police have, that camaraderie of just working with the same people all the time in a very, very tight confinement in the living quarters and stuff. So again, it's just kind of a couple different things. The one on the left is actually Elm Creek. The one on the right is a beautiful shot of about 1,500 feet of Southern Ohio. And again, these are the views that you were coming to get when you're air medical. And like I said, looking at it from a different perspective, it's absolutely gorgeous. I'm not going to lie, it is really, really cool. The different perspectives you get from flying out, you kind of taking your views on top of everything. Obviously, the one on the left is downtown Columbus, and the one on the right is more Southern Ohio. Like I said, you can kind of get a feel for how beautiful it is. I think the Athens area down by OU is just so beautiful to fly over and get that view and stuff. So, again, depending on what type of sports fan you are, this is West Virginia. I've been down to Morgantown a couple times, and then Ohio Stadium, obviously on the right. This is right by the airport, right by the helipad at OSU. You fly over this all the time, kind of getting. Like I said, some different views, some different perspectives. I'm going to tell you, this is the part of nursing that you will never get working in a hospital or anything like that. So if that's something you really, really like I said, it's a pretty cool thing to come in. Similarities, when you look at trying to compare a nurse that works in a hospital or a health system compared to that, there's all kinds of accreditations, licensing, paperwork, everything. We have what we call CAIM standard. That's our JCO for that. So again, a lot of paperwork, a lot of different things we have to maintain to prove that we are good at what we do. Again, I'm not going to lie to you, paperwork stinks. We do a lot of charting on a computer system, and half of our life is charting, just like you're going to get used to when you get out of it and stuff. So again, it's still nursing. You're still providing care. We're still holding hands. We're still doing the things that we do, when we look at similarities that come in. Perks of the job, I will tell you, and again, you can kind of look at it, the top right picture here, the people, the atmosphere is just unbelievable. This is a flight crew to the right. You can see coming in, and these guys work together all the time. A lot of them are from that region that they're working with. So it's just a cool thing to come in. The bottom picture is actually the whole base staff. So when you look at those 10 people and the guy kneeling down in the middle is the mechanic, those are the 10 people you work with on a regular basis. So again, it's kind of like picking 3 or 4 or 5 people you work with in the hospital and work with them on a continual basis all the time. So that, I got to tell you, that is really cool. We don't have to worry about cafeteria food. The one thing I will tell you about the paramedics you work with, a lot of times work at the firehouse, they are damn good cooks. And so are the pilots. The pilots come in a lot of military. You eat well. They have all kinds of recipes. We really don't eat out a lot. When you bring to the base, you will bring food. There's certain paramedics that bring steak and chicken and all that, and they cook it up very well because you have a full kitchen. So again, I will tell you that that is a huge perk, and it's a lot of fun coming in. It's just like being, just like the fire department. Some days are very, very busy, and you're busy, and other times, you could go a whole 24 without doing anything. So again, it's kind of one of those hit or miss type things in terms of treatment and stuff. The one thing that I will tell you that for nurses and, especially this field, is you really have to turn it on and turn it off quite a bit. And this, like I said, we kind of got this picture up here for, Maverick, and you got seen Top Gun. He talked about, being, going Mach 2 with his hair on fire. And that's kind of the thing that we do. And we turn it off and turn it on very, very quickly. You can be talking about a conversation, talking about something going on, and then bam, we're ready to go right off, coming in. So this is some of the things you will see without it coming in terms of trauma. Alrighty, guys. So again, this is kind of, we'll give you a couple different scenarios coming in terms of this is kind of what's going on. So this is a real life case. So again, you're sitting at your base, you're having coffee with the group you have, and lo and behold, this is what's going on about 3 miles from your base. You have a rollover accident, you have a trauma. We are in Southern Ohio, so there is really no trauma centers within probably an hour and a half drive. So again, this is definitely you can kind of look at the weather. This is definitely an air medical transport. It's met the criteria for the trauma, coming in. So you really don't know this is going on. You're sitting in, drinking your coffee, you're coming in, and lo and behold, the police and the EMS agencies on scene for a potential. So really what would happen in this case, so as somebody comes up, the call is going to go into our communication center. And the call is going to be, whoever you are, fire department A, fire department B, EMS agency A, B, or even the state highway patrol, and said that they got a patient that needs flown. What they're going to do is, I go back to this picture, they're going to say a GPS location. They are a target on so-and-so road coming in. And what will happen is they will tell our communication where they were, and they will GPS that location. Once all that information is taken from our communication center, the call is going to go into the pilot. And the pilot is going to see if we can do the run. So again, this is back from 2017. But again, it just basically kind of goes into, so the call goes into the pilot. The pilot's going to make the call. He's going to go, can we go from point A to point B? And he's going to say either yes or no. If the pilot accepts a flight, it's a go, we're ready to go. If the pilot does not accept the flight, then it's turned down for weather, and then they're going to look at other means of transporting the patient. A lot of times, if not, what they will do is we have fly cars that can potentially go meet them. We have a vehicle that we can put our equipment in. And so there's other options out there for our people. But again, this is just to kind of come in. So this actually was a scene go. So the pilot came in and goes, yes, we can fly from point A to point B. So again, at this point, it becomes a go, and we're ready. So again, when you kind of look at it, you're sipping coffee, you may be eating breakfast, or finding out what somebody did last night, talking about your kids, talking about something, maybe related to weather or vacation or something, and bam. And as soon as this flight is a go, you really kind of get into your mode of, now I'm on. So again, when you guys walk out, we are going to go through a pre-flight as a team, and we're going to walk around the aircraft to make sure the aircraft is ready to go, and then basically get our helmets on and we'll go. So when again, we kind of use the term game time. It is game time, face time, it's ready. So again, this is our helmet. It's laying in the bottom left-hand corner. We get in the aircraft. The pilot will start the aircraft up, and the most important thing right now is to make sure the aircraft's ready to go. It is a mechanical machine, so we got to make sure everything's functional before we go, coming in. So again, like all those checks are in. The pilot says we are ready for flight and we're ready to go, coming in. Our next piece, as you can kind of see, this is our base MedFlight 6. This is taken off, and you're en route to the scene. Now, when we get up in the air, we are going to make radio contact with the EMS agency. So again, this basically works. They give us a frequency, and we're going to call them and say, hey, so-and-so fire department, this is MedFlight 6, whatever. We have a 5-minute ETA to your ground transport. Tell us a little about where we're going to land and what's going on with the scene. And this really becomes a really, really crazy thing because, to be honest with you, now this is the danger point in the flight. We are flying into an area that is not designated a airport, designated to have things fly around in it. So it becomes a real critical piece in terms of flying in, because we're going to fly in to make sure this area that they designated for us to land in is very safe for us to land in and stuff. I will tell you, people do a lot of stupid things when you kind of fly in. When they see a scene and they come in, a lot of people want to go see the aircraft, and I've had vehicles all drive up and they want to see the aircraft coming in. So it really becomes a safety issue the first few minutes on the scene. It gets kind of crazy and very emotional coming in. So again, we can kind of look at it. So what we do, we get the helicopter safely on the ground, and lo and behold, coming in. Now, when you look at some of the things we're going to be careful of, the aircraft has wings on it. I'd look at the wings as the rotor blades. Those are the ones that's going to give us lift, and they don't do well when they hit things. Absolutely, they're going to shatter, break, fall apart and stuff. So anything that sticks above the ground is coming in. And these are some of the pictures you will see, and you can kind of see in the bottom left-hand corner, you can see that water tower, but you really don't see the power lines that's on that road. And I kind of put that picture in there because a lot of times they'll say, oh, you got plenty of room, you got a baseball field, you got this to landing and stuff. And we really have to pay attention to where we're flying into, make sure it's not obstructed. The pilot does what we call a rendezvous, and I call it the toilet bowl. We will fly around the scene in a circle, and we circle around the scene 3 times to make sure we're calling out everything. So at this point, we're not worried about patient care. This is all about getting this aircraft on the ground safely. So we're going to call out everything that what we see coming in. Now we exit aircraft's in scene. We're on the ground, and the extrication is still in progress. What that means is the patient is still pinned in the vehicle and they're coming in. So again, you're trying to get, the one thing I will tell you, trauma is all about reenactment. So I don't know if you remember seeing that picture before, but it's all about looking to see where the patient was and the forces that exhibit on that body. When you think of trauma, you think of all the sustained forces and where did they sustain the force. So what type of force was it? When you have a rollover, that's going to be all over. When you have a head-on collision, when you have a T-bone, wherever you're going to be, it's all about transferring energy. That energy is going to get transferred from the accident into your body. And we're hoping that, again, you're wearing your seatbelt and doing all the things you should do. But again, that's not the case usually a lot of times. All right. So this patient is extricated and actually in the back of a vehicle now. All right. So what we've done is we've taken him from the scene, and you can tell from the paramedic that's bagging this patient really does not have a patent airway. She is not breathing really well and doesn't really have good breath sounds at this point. So we're coming in. What we're going to do is we're going to assess her, and it's kind of a dumbfounded look. Not one of my best pictures, but I will tell you, that somebody opened the back door of the squad and just snapped this picture. I didn't even know this picture was even being taken. Somebody just opened the door and snap, and took the picture, and then everything. So again, like I said, it's one of those just, oh, who's coming in? And then lo and behold, the picture's taken, and then they close the door again. So again, this is where your EMS skills come into play, with this patient. So again, you can kind of see I got a laryngoscope blade in my hand. We're going to be intubating this patient, and we're also going to what we call needle decompression in the chest. We don't have much air movement, and those are all life-saving interventions for this patient. So this patient is pretty beat up on pretty severely traumatic injury. So we're coming in, we're doing the evidence of kind of your basic steps. You are going through your algorithms. These are all your training in a nutshell. So you kind of approach a patient just like you would when you're coming in. We're looking for life-threatening injuries right off the bat. If there's any type of bleeding, any type of this, any type of that, there's a major ventilation issue. We do not have breath sounds on the right side, even though she's adequately bagged. We need to have a life-saving intervention called a needle decompression. We have to relieve that air so we can make sure the lung can inflate and we can ventilate. She's not awake. She's not maintaining an airway, so we're going to have to intubate her. So this is where all your training go in. And I will tell you, when you look at a controlled environment, this is not a controlled environment. These patients can be combative, they can lose stuff, and you got so many hands on it. You got EMS, you got law enforcement, you got yourself, and these can be kind of crazy, coming in. If you can kind of see what happens here, paramedic put an IV in at the scene, and lo and behold, this patient gets a little bit combative on you, and now the IV gets pulled out because of a crazy scene and stuff. So again, like I said, it's one of those things that if you like really controlled and you like everything within the realm, and you're that nurse that's going to label all your medications with tape and say this is this medication and that medication, probably MedFlight's not for you. I vowed it's more of organized chaos. It's a fun, definitely organized chaos in the best. So we're able to get 2 large bore IVs. We maintain his patient. We did give some medication so we can secure her airway. We're going to do what we call a rapid sequence intubation. A lot of our medications are weight-based. So again, we're going to calculate our etomidate and our sux dose on what this patient weighs and kind of go in. And that's working off our protocol system. So it's not a physician telling you you're going to give this amount of etomidate, this amount of sux. You're going to have to calculate that on a weight base. So our protocol says this, our protocol says that. So again, when you kind of look at the first attempt on intubation on this patient, we still got unequal chest rise, and we're going to needle decompress again. Think of a needle decompression as what we call a pneumothorax or a tension pneumo, and there's air between the chest, pleural space, and the lung. That air is pushing on the lung and will not let that lung inflate. So we're going to have to do what we call a life-threatening emergency, would be needle decompression. If this would happen in a hospital, you would put a chest tube in. So again, we talked a little bit about doing training for chest tubes, but right now the life-saving emergency is to needle decompression. So you kind of go through your walkthrough. Now we are medicating this patient en route. We are getting this patient out of the EMS vehicle, and now we're coming into our air medical side of things, and then we're going to get them off the scene and back to the hospital for where they need to go in terms of this. This is kind of us pulling her out. You can kind of see the patient is intubated at this point. We'll make sure that tube is secure. You notice my left hand is on that ET tube. That is one thing that we guard with our lives in terms of tubes and bodies. We've got to make sure this is where we're going to transfer from their cot to our cot, and we're going to get the patient loaded up and take them to the hospital coming in. En route to the trauma center, you can kind of see what's actually going on with this patient. Unfortunately, her blood pressure drops a little bit, heart rate's going up. The SAT maintains, she's doing okay in terms of that. So you're going to reassess. She does have what we call crepitus. She's got some air leaking around her chest. She definitely needs a chest tube when she gets to the hospital. And she also has what we call a hemopneumo, which she's also got blood in her chest too from injuries. So we're talking about fluid boluses at this point to get her a little bit of medication called TXA. TXA is a medication that will help her clot so she doesn't bleed to death coming in. And this is all part of our protocol treatment. And this is kind of like old hat in terms of being focused in on what's going on with their patient and going in. Like I said, and then working with the guys you work with, when you work with them on such a consistent basis, you don't even have to say anything. It's just all about the way we look, the way we do things and everything. And it's kind of cool coming in. We will give a report to the hospital. You can kind of see from the bottom part of it. So with trauma, it's all about a reenactment. So this hospital, first of all, wants to know age, and they're going to want to know where this patient was and what happened to the patient. So this would be a rollover MVA or MVC, motor vehicle collision, along with how was she found in the vehicle. She was unconscious, she was not breathing very well, and she also had lung tissue injuries and chest injuries from her chest. So again, like I said, and then a focus report coming in. This is us en route. Like I said, we're doing all this very, very important stuff, and we're calling in it. It's very, very difficult to hear in an aircraft. You are not going to be able to listen to breath sounds. You're not going to be able to do pulse checks and stuff. So you really have to heavily rely on everything you do on the ground to make sure everything's in right before you take off. Because once you take off, you're not going to, revert back to, shut the aircraft off so I can hear breath sounds. You are kind of stuck with what you got. So it's really, really important to maintain all that stuff. And we're given a detailed report to the hospital. On approach, without warning, this maybe the patient starts waking up. I've had this happen a couple times. And again, you've got to worry about, we don't want to have anybody coming in and grabbing the pilot or anything like that to realm. So you have to really, really be sure, MedFlight, you have your control of your patient. You give a little bit of sedative dose, you give a little bit of paralytics to paralyze this patient to make sure they're calm before you offload the patient. This is the one thing I will tell you, very unpredictable. These are intoxicated patients, patients that have a lot of recreational drugs on board. This can be a problem. So again, you really have to be very, very in line with what's going on. So if a patient did come on bad, what are you going to do? I don't want to be 1,500 feet on the ground fighting a patient, coming in. So we don't do a lot of that. Or do you want to do that? Here's at the hospital. This is Ohio State University Medical Center's level 1 trauma center. As you're coming in, if you'll notice, there's 1, 2, 3, 4, 5. I don't know if you guys have ever been to a trauma center or seen them act. There is really, it should be a well-oiled machine. The majority of the time it works very well. As soon as we get there, there's what we call EMS or hospital timeout. And that is when you give them report. And a report is, again, it's going to be patient age, patient sex, and it's going to be really what happened to this patient. A rollover MDC. Rollover means they got forces from all 3 sides. And again, so it's really hard to tell exactly where the forces came from. So that's pretty significant. They're going to want to know an extrication time. What does that mean? That means how long it took them to get out of the vehicle. This was 20 minutes coming in. The longer that patient takes to extricate, the more significant the injuries are going to be. And if you notice, if you see the female doctor up at the top, she is the emergency room doctor. If you think about where they're located, everybody's got a job to do, and we should assess this patient in 5 minutes. This patient should be completely assessed in about 5 minutes. So you have your ER doc at the top, assessing airway and head. The next gentleman is going to do chest. The next gentleman next to him is going to do pelvis. And then the last female on the right is going to do legs and stuff. So again, everything is about assessment, and we're going to go. We're either going to go to the operating room or we're going to go to CAT scan within 5 minutes. And that is the goal of the trauma center, to completely go through this, see what we see, and treat accordingly. So again, it should be a well-oiled machine. I mean, it's pretty cool coming in. So we arrive at Grant, we give a fast, and they were able to do what we call a fast exam, which is a fast ultrasound. Doesn't tell you what's bleeding, but can tell you that there's blood in there. They were able to do a left chest tube, about 250 cc's of blood popped out. And again, it happens simultaneously. You got somebody doing a fast exam, the one doing the belt on the pelvis and belly, and then you also have a doctor putting a chest tube in. So they are completely a well-oiled machine and doing all that. So it's kind of cool to watch a trauma service if you ever get a chance. I don't know what your guys' background is, but again, it's pretty cool to watch them assess, where you got multiple people working together to get this patient assessed to come in and stuff. So lo and behold, as you come in, maybe it's a bad day out for weather. The pilot informs you, you're stuck there. You're there for 90 minutes. There's a weather front moving through and maybe thunderstorms or something. So you're stuck at that hospital for 90 minutes coming in. So you find a cafeteria, or you may just, kind of come in, find the EMS room and, take it easy and maybe get your chart done while that period is going on. So again, like I said, it's just kind of one of those things of such an unpredictable time. I will tell you, one of the negatives is it's not a 9-to-5 job. If a call comes in 15 minutes before your end of your shift, you're going to have to take it. So again, it's kind of some of the things. This is us coming back to the base, and lo and behold, it is time to debrief, make sure everything went well, coming in, and lo and behold, it's just kind of the thing to kind of get back everything, get restock, refuel, and maybe get your head back on from this, pretty significant trauma patient. It was pretty cool to do. You're able to do needle decompression, you're able to do intubation. This patient get an interosseous line too. Some of the things, like I said, you would not do in the hospital coming in. They get everything ready. Lo and behold, this hospital calls. Hospital A, which is in your service area, calls, and now they got a patient in the emergency room that's got a stroke. So again, we just back at it. We're back game time, coming in. Now we'll tell you before we do that, as you're flying out, OSU calls back or texts back all the injuries your patient have. So we got a pneumothorax, we've got a hemothorax, we've got a fractured spine, we've got a liver lac, we've got air in the belly, and we've got a partial diaphragm rupture, which is probably why she had decreased breath sounds on both sides. So again, this is kind of pretty cool when you're coming in. This patient actually did pretty well, but that's a pretty significant injury. It's amazing to me how trauma just tears your body apart. Everything just from your bones, from your structures and everything. And like I said, trying to find out what they are quickly. Here's just a couple shots of it, just a couple of scenes. This one is pretty significant because I'll be honest with you, a lot of especially smaller communities monitor radio traffic. This was a couple that was involved in this car crash, and lo and behold, they actually came to the scene as they lived about a mile down the street. So not only do you have, the fire departments, and again, not picking on the small communities, but it feels like everybody knows everybody. So again, it kind of adds to your stress level, coming in. I will tell you the EMS and, even the MedFlight standpoint have a pretty high suicide rate. And that is not really, we are great at taking care of other people. We are horrible at taking care of ourselves. And this is one thing I will highly suggest to you guys is making sure that you're taking care of yourself. It is never okay to have a death. It's never okay to have a really sick patient and maybe had a bad outcome. It's never good. People are like, oh, you can turn it off and turn it on real easy. Well, you think you can, but then you take it home and maybe have, spousal problems, marital problems, and then you end up down the line of, coming in. So really take care of yourself, because some of the stuff we deal with is just absolutely horrible, coming in, depending on what it is and stuff. So when you kind of look at the situation, it's pretty significant. This is just another picture, another scene we were on coming in, and you can kind of see the airbags deployed on this one, the seatbelt cut off. So when I come up on the scene, I don't go to the patient first. I go to where the vehicle is, and I want to see the forces coming in. You can tell it's really hard to tell on this, but this steering wheel is bent. So again, I don't know, even though this patient had a seatbelt on, the impact of the steering wheel. Think about bending a steering wheel and how hard I'd have to hit that. So again, I'm thinking chest, I'm thinking pelvis as they slide underneath, and all kinds of injuries that you would focus in on this patient just by looking at this stuff. So again, like I said, really cool. It's like, running with your hair on fire. But again, like I said, it can add to some negative feelings too, because these are people's lives. These are family members and friends of people. Just another shot of a motorcycle accident. I used to think at one time I wanted a motorcycle. After going through, this guy was in a ditch, really screwed up. It's never the motorcycle person's fault. It's always somebody cut in front of them and stuff. So again, some of the most craziest, most horrible runs I've ever been on have been definitely motorcycle accidents. I think they can't protect themselves at all. When I'm in a vehicle, the vehicles nowadays are just so good at protecting you, but motorcycle accidents are just nasty. All right, let's go back to our other run. So again, we got a stroke alert. Now this is a little bit different. When we are landing at the scene at MedFlight, we are basically accessing a patient and taking them to the closest level 1 trauma center. When we pick up a patient out of a facility, now this is an interfacility transport, it's about 50-50, 50%, 50%, coming in. So this is an interfacility stroke. When we're picking this patient up, now hospitals have to have communication with another hospital. So again, when that patient comes in and they're diagnosed as a stroke alert, we are taking them from one facility to the next. They have to make contact, and the patient has to be accepted at the next facility. So again, we start with our trauma case. Now we're going to revert back to our stroke. And this is going to be, kind of coming in of our stroke assessment. We're going to manage blood pressure. We're going to do all the things we're going to do just like you would on a stroke alert coming in. Just like you would just normally assessing your stroke, you're assessing the severity of it. A lot of times, TPA is an option. If you guys have seen some of the stroke mobiles out there coming in, those are about 80% of stroke is caused by blood clot, and we can dissolve that clot with clot dissolving medication called TPA. So you will see TPA administered a lot on these patients coming in, and this is what we're going to do. So we do a lot of what we call focused assessments. It's not that head to toe. This one would be all neural. So I'm going to assess this patient for neural symptoms and stuff and take them to the neuro center. No different than anything else. You're going to basically take them into the facility, drop them off, give them a full report, and fly back. So now it's about 10 o'clock in the evening. You have your nightcap. Maybe you, again, they do a little debriefing on the 2 transports you had, and lo and behold, you go to bed, you lay down, and you're off at 7 a.m. in the morning. So you're thinking about what you're doing for the next day. And lo and behold, the phone rings again, and it's a STEMI alert. So again, you kind of going in. Now you have a patient having a heart attack or a EKG changed with symptom heart attack, and this is kind of come in. Now this is where you kind of come in. This is the EKG that's pushed on you when you get to the facility. You can kind of see from the left side of the EKG significant ST elevation coming in. And why I kind of bring these three runs up is because of three different focuses. The first one is all trauma and using all your trauma skills. The second one is using all your neuro skills. And this one is using all your cardiac skills. So you can kind of see you have to have a little bit of everything in terms of reading EKGs, doing a focused neuro exam, and then doing your trauma stuff, coming in. And lo and behold, they don't tell you this, but you find out at the hospital, they have an Impella device in. You think of the heart as a pump, and this is all the different things that kind of come in to help the pump going on. If you guys are familiar with some of the cardiac devices out there, these are definitely some of the things you will see out in the field, coming in terms of these put in. And the next one is what we call a balloon pump. So some of the things we have our staff take care of. So again, it's just a wide variety of stuff we do to maintain and stuff. We do what we call a ride along. This is Tyler Altieri, is one of our flight nurses. This is his wife. She came to the base and took this picture, but I highly suggest if you have any interest in the field to come in, you can observe www.medflight.com and come in and observe this for the day. Kind of see what it's like to fly, see what it's like to do what we do. And again, if it sparks your interest, that's great. Again, that's a neat thing about nursing is there's so many different avenues, so many different fields to go into. If you don't like something, you can change pretty quickly, coming in. So, and about 50% of our runs are scene runs. What I mean by scenes is we land at in a grassy field, on a road, wherever we can land aircraft at the scene. And then the other 50% are in the facility coming in. So again, like I said, it kind of gives you an example of what it's like. Like I said, it's a wholly different field. I will tell you, it's nothing like I've ever done in nursing. I came to MedFlight with cath lab experience, ER experience, and ICU experience. And those don't compare to what it's like to be, again, in terms of MedFlight. It's really, really cool. You get to know so many people, so many different people, and so many different places I get to fly into. When you look at trauma, I love this slide in terms of, again, these are probably about 60-70% of what we do. We call them stupid people. But again, I'm telling you, some of the stories I made up, I wish I would have kept a log. I've had patients that we got called, just a couple interesting runs I got called off on. We were out on a scene in Madison County, and we're flying out there, and EMS tells me the patient was run over or gored by a cow. And I'm like, a cow? And I'm like looking at the paramedic, and they're like, you are a city boy, aren't you? I'm like, yes. So I get there and we land on scene, and we talk to this lady, and she's pretty screwed up. She's got a fractured pelvis, she's got broken legs, she got a broken arm, and she's got some chest injuries. And I'm saying, so what happened? And she said, well, she got between the cow and her calf. And I didn't know that, in terms of, maintaining, you don't get between mom and everything. And this cow actually charged him and stuff. So I'm like thinking, okay, city boy, hey, how much does a cow weigh? And we're like, well, they weigh, 800 pounds or something. I'm like, whoa, that's a lot of weight. So again, like I said, you kind of get a feel for, a lot of different things and see a lot of different things and stuff. But when you look at trauma, like I said, you can't make up some of the stories. Pretty funny in terms of that. This is Tyler. I love the photo bomb on this patient. It's kind of interesting. It's a chest X-ray with the head. Guys, if there's any questions about anything about MedFlight, anything about what we do, how we do it, I guess you can probably go to the chat room, or you can unmute yourself and ask. I got my speaker out. What do you got? Any question wise? Anybody interested in MedFlight? Anybody interested in air medical? Oh, guys, okay, so just a couple questions. It says, there's a couple people that's interested. I love it. Like I said, um, we don't have a lot of turnover for our nurses. Just, I think once you do it, you really, really like being, first of all, not tied to a hospital or not tied to a healthcare system. You're kind of out and about. Um, but again, I think it's like I said, it's we do. You know, I've been here 20 years, and I'm in the middle of the road in terms of tenure. I've got nurses have been here 25, 30 years and stuff. So again, I think it's a pretty cool thing. When you look at MedFlight for a ride along, as somebody asked about a ride along, we wait till you become a nurse. We used to do students, paramedic students, and nursing students, and just got completely bombarded with too many. So we usually wait till you become a nurse or a paramedic. And once you guys do that, everything's done through our website. It's www.medflight.com, one word, medflight.com. And it talks a little bit about the observation program and what you can do to good. I'd highly suggest it. Like I said, if you have any interest at all, make sure you do that. We do get a lot of nurses that actually talk that want to do it. And I will be honest with you, the best advice I can give you is we have a podcast system called MedFlight Radio, MEDFLIGHT Radio, and it's a podcast. And there's three. One of the podcasts is a critical care nurses podcast for nurses that's interested in working in air medical, not only at MedFlight, but at all air medical situation. And these nurses talk a lot about how to better prepare yourself for a job here at MedFlight. So again, everything's done. So observation time, www.medflight.com, and everything's kind of going through that and then kind of give you questions. You're more than, if you want to come through Haley and ask her and go through me, you're more than welcome to ask questions about that too. I would love for you to come visit us, again, when COVID lifts. It's a little bit better to see. There's 3 aircraft sitting here. Matter of fact, I'm looking out my window. There's an aircraft. The crew just landed here, and I could show you the aircraft and show you the things. Kind of doesn't do it justice when it's just seeing it through a picture, but again, kind of gives you an environment you're coming in and talking to some of the crews and stuff. But pretty cool thing. I love it. Like I said, I've been in quite a few different areas of nursing before I came here, and I do like it a lot. I think it's a really cool job. I think a lot of people love what they do. But again, it's just a different element. You have to like a little bit of some, organized chaos and having different things every day. I could go in and pediatrics and OB and, now a COVID case, again, just so many different things that you will see on that. Again, I got another question, guys, in terms of review and education certifications info. Again, really, we want your nurse to be between 3 and 5 years of critical care experience. My best advice to you is to do about 2 years of emergency room and 2 years or 3 years of ICU, because you're going to need a little bit of both. The ER is all about stabilization. So those are going to be the patient that just walks in and your initial wave of hitting. So that really doesn't talk about ventilator management, vasopressor agents and stuff, because a lot of times the ER just stabilizes, move on. When you get into the ICU, that's going to be more lab interpretations and following labs and trends, high dose ventilator management, and some of the things you're going to have to deal with. And those are the 2 type of patients we transport. We transport the ones that are in the ER that have only been there a couple hours, maybe 15 minutes, hour or so. And then we also do the ICU patient that's been there for 3 or 4 or 5 days. So you have to have a little bit of both. That's my best advice to you, to preparing yourself. In terms of certifications, all of them are good to get. You don't have to have them to interview, but I do highly recommend them. That would be ACLS and BLS. That's kind of pretty straightforward. PALS is a good one. And ITLS, or Advanced Trauma Life Support. Those classes are pretty readily available, and they kind of give you the basic behind treatments and stuff, coming in. That's what I would recommend doing, to kind of better prepare yourself coming in. What would be the best case scenario for a career resume when applying? To be honest with you guys, we are in a pretty good situation because a lot of our crew members here at MedFlight are pushing 60. Nothing against age, but that's probably going to be a pretty good mass amount of exiting in terms of retirement. Again, and we've had nurses here that I've been here 20 years and, pushing 30, 35 years. They've been in flight. They've been a lot. They've seen a lot of changes, but they've also been part of the flight. So you're in a pretty good situation. Get your nursing degree, and then get your experience that you need. We really, really highly focus on this the experience. That's going to be a big one. That's going to be a big one. We're going to, because a lot of questions you're going to get asked in the interview process is how comfortable are you with cardiac, with neuro, with trauma, and with vascular alerts. Those are the four biggies we transport. Those are our very, very time sensitive cases, coming in, and we want you comfortable. We want you comfortable assessing, interpreting labs, interpreting EKGs, and all that. So again, I'm going to go through. How long do you stay at the base? Like when you get to go home. So your shift is 24 hours. So again, usually each base has a stagnant amount of time that they start. Some start at 7:30, some start at 9. So you would report 15 minutes prior to your start time, and then you're going to complete your shift up to 24 hours. So again, if you don't get a flight at the end of your shift, then you would transfer care or transfer everybody to the next shift and stuff. So our shifts are 24 and 12. So again, the majority of them are 24, but we do have nurses that only like to work 12-hour shifts. So it's a combination of things. If you're full-time at MedFlight, you will definitely do a 24 and 12 a week. That's how it works. So you'll do 36 a week, and that's a full-time person. And if you want to pick up, obviously you can pick up. So again, it kind of works out very well. How long do you stay at your base? You get assigned a base when you start, or a region, and you're going to stay at that base as long as you like. Again, like I said, sometimes it may not be the base of your choice. So somebody really wants to get a job here at MedFlight, and maybe the closest base is not have an opening. So you would get assigned to another base, but you really want to get on here at MedFlight. So you will be assigned to that base, the base you start with. And then when an opening comes up, you would just bid just like anything else. So if an open shift comes at an open base, then you would bid on it and stuff. But they really do a good job of keeping you very, very close to your base. Again, we got bases all over again, and not to, talk a little bit about that, but, one in Gallion, which is north. We got one in Coshocton, which is east. McConnellsville. We have one on the river in Meigs County. We have one in Union County. We also have that to the Dayton area in Eaton. So again, it kind of goes through, and also one in Jeffersonville. So these are kind of the bases of sporadic. So sometimes you don't get exactly what you want, but again, a lot of people will just apply and then get the spot and then transfer if they need to. Really good question. Next one, guys, how do you handle COVID cases? And those are very, very tricky because we are very much in a confined environment, and you're really worried about COVID cases, aerosol, and treatment. So again, a lot of times we really would like to see the patient intubated. When they're intubated and on a ventilator, that means all their lung contents are contained within that. The problem lies into they're not all intubated. They may be on CPAP, they may be on BiPAP, and they're breathing 30, 40 times a minute. And that can be a big problem because we're in a tight confinement, and they're spewing out all those aerosol COVID virus coming out. So it became a little tricky. We originally weren't flying it just from the case of our pilots, but the last 6 months we've been able to accommodate that. All of our crews are vaccinated, and we have special masks, and we'll gown up and we will do the whole 9 yards, just like you would do in the hospital. You're going to gown up everything, mask, goggles, and everything, and try to maintain that patient coming in. But I will tell you, these COVID cases, guys, the ones that we're getting are not the ones in the emergency room. These are the ones in the ICU that have been there for 4 or 5 or 6 days, and they can't ventilate them and they can't oxygenate them. You get there and they've been just not handling the vent at all, and they're going to a higher level of care for ventilator management. And it's really tricky because these patients are super sensitive, and moving them is significant. I mean, just moving them from their bed to ours, they can drop their sats significantly, and they become really, really hard. And I'm not going to lie to you, they're very, very challenging. And we've had a few COVID cases that we did not transport. We just could not stabilize them enough. We were afraid that if we transport them the rest of the way, we would hurt them, and they would not survive. And they probably didn't have a great outcome anyway, to be honest with you. But again, and the COVID, again, you guys have probably been drilled on it enough. We're kind of seeing all age groups. I think some of the people, if you're over 70 is the only one you see with it. And that's not necessarily true. We've had some really sick COVID cases in the 40s, 50s, 60s that were pretty healthy people. coming in. Now they're tied to a ventilator and they're not doing well at all. So again, this can be really, really tricky coming in. Those are not the fun type of patients, guys, to be honest with you, because wearing a mask, wearing a gown, wearing goggles, and the pilot has to do the same thing is not fun. And you will just absolutely bake and sweat and everything in the aircraft. So it isn't the funnest type of transports and stuff. So if you were observing and we did a COVID case, you would not go. We would leave you to base. Uh, Again, another question, somebody it definitely is interested in, how often do you get pediatric patients? If you would have been here, again, not to pound it in, but if you would have been here, Nationwide Children's also has our major hospital here in Columbus, Ohio, has an aircraft in their ground unit here. So we don't do a lot of pediatrics, but we do, when we get a pediatric, it's usually a really, really sick one. So they can be challenging. So pediatrics fall in our about 5 to 10 percentile range. And it's just hit or miss, to be honest with you. You can get some guys have transported hundreds, and others maybe 2 or 3. But again, when it's a scene, that's probably where you're going to get a lot of our pediatrics. So if you go on a scene of an accident where a pediatric patient is injured, you're going to get that pediatric patient, and they're going to take it to the children's center. So anything under 16 years of age is going to go there. So that's a piece that you will already know going in to your flight coming in. You're going back to Nationwide Children's. How long do you stay at base? Any height requirements? There's no height requirements. We do have a weight requirement, and it's the aircraft. It is 225 pounds, no height requirements. I will tell you, some of our nurses that are a little bit shorter probably are a little bit better. You cannot stand up, and again, not to beat a dead horse, but if you were here, you can kind of see what the helicopter is. I'm 5'9", and I can't stand up straight up in the aircraft. You're kind of slunched over a little bit. So again, when you kind of look at it, there are some of the negatives too, guys, to be honest. Getting cramped in an aircraft over a long period of time can wear on you too. So that's something you got to think about. Do I really want to do this? And so most of our crews love it, but again, like I said, there's some negatives to that, coming in. Good question though. Do you always return after the base after a run? Yes, you are assigned a base. So they want you in that service area. We specifically put that aircraft in because there's really very few resources, especially in Southern Ohio. So as soon as you drop that patient off, a lot of times the pilot will be refueling while you drop the patient off. So again, your job is to drop that patient off, give a report, and get that aircraft back. Now, there are definitely some circumstances that would change that. If you had a COVID case or a patient that had a respiratory virus or some type of thing where it's spread, then you would have to decon the aircraft, which is, again, not the funnest thing in the world to do. Once you drop a COVID case off, you would have to decon the patient or decon the aircraft at the hospital. So you would be out of service until that. But the goal really is with everything is to get you back to your service area where you're coming in. If you're from McConnellsville, or if you're in Portsmouth, or if you're in, Galleon or Coshocton, get back there, because that's the only aircraft they have in that service area. So again, we want that, make sure to coming in. So when you guys think about it, a lot of our transports go back to Columbus. So there's a lot of resources in Columbus. There's not a lot of resources to farther head out. So again, and that's kind of the main thing coming in. Good question. How do you guys handle pregnant moms? Does that change if they can fly? The one thing I will tell you with pregnant moms is if birth is imminent. So there's a certain criteria we have in our protocol. If birth is imminent on a scene, we're going to deliver the baby on the ground. We're not going to try to put this patient in the aircraft. Second of all, if it is a patient that is maybe that you suspected, we will flip the patient around. The patient will be put in backwards on the aircraft, so their legs will be facing you, not their head. Coming in. So again, and it's kind of a little bit, we don't do, most of our OB patients are high risk OB, and preterm labor seems to be the big one. Preterm labor or having contractions early is a lot of what we do. A lot of patients that are on mag sulfate, a lot of different things that help prevent that. And again, back we're to our high risk, low volume type runs. Those are the runs that we don't get that often, but they can be, crazy, because now when we add pregnant mom, you add a second case area, second person. So that can be a lot challenging. And, again, I'm all about, we are not delivering a kid in an aircraft. I'm adamant about that. We will do everything we possibly can to try to do. That's just not a good environment to do to deliver that. So again, if we could kind of get on scene, look at the person, and then kind of make a decision on that. Career resume. Yes, that website is correct. Somebody wrote, I think Hope wrote it. It is www.medflight.com. Everything's on there, and it definitely talks about observation time. You can pick a base. Highly suggest a nice day. Don't do it when it's cold. Like this is not any fun to be out in this cold weather. It takes a long time for the aircraft to warm up and stuff. Get towards the, and we call them the weekend warriors. As the weather starts coming nicer, maybe in March and April, people start doing stupid stuff. So your trauma cases definitely pick up. Again, and I think that's the funnest time. We can have a chance to get out and not be so restricted on weather coming in. The weather really, the aircraft doesn't really care if it's really hot or really cold out. It really doesn't matter for that. But I will tell you the problem with the aircraft is it's ice cold. And when you start it up, it's kind of like your car that's been sitting out all night. It takes forever to warm up. So again, you may get in this aircraft and it may be, maybe 20 degrees when you get in that aircraft and you're flying for 10 minutes and it's maybe 30 degrees now. So again, it really takes a long time to warm up in this cold weather and stuff. So definitely, again, it's just keeping the elements in line. I will tell you from a nursing standpoint, one of my first runs, and I'll end it on here, but we did a case, and just like it is today, it was really, really cold out, and this guy owned his own salting company. So he did sidewalks and everything. I didn't know salt came in pallets. So his pallet came in, and so he had a auger that he would put this pallet in to grind his salt up and make it into little pieces so he could run it through his machine and salt sidewalks and everything during the winter months. Someone coming in. Well, so we put this pallet in. The pallet got stuck in the auger. So he tried to push it down with his foot, and lo and behold, when he went to push down with his foot, he missed the salt pallet and put his foot through the auger and everything. So again, it was a day like today. It was probably 15, 20 degrees out. We get called in, and this guy's got his whole lower leg in his auger. It's all it's mangled. It's in pretty bad shape. We get called out to the scene. It's one of my first transports. So again, I'm thinking my full focused assessment. What am I going to do? I'm flying there, and it's, again, I'm trying to think. I'm with a paramedic that's been there for 20 years here at MedFlight, and he looked at me and he's like, everything's going to be fine. Just take a big deep breath and we'll do it. So, but again, I'm the new guy. I'm trying to prove myself. So and everything. I get on scene, and what's going to be my management? I'm going to try bleeding, make sure try to get as much peace as I can, and pain management's going to be in there. So how do you give pain medicine? You give it through an IV. So lo and behold, I get in, and what's an IV going to do in 15 and 20 degree weather? So, yep, you're thinking the same thing I'm thinking. So I get there, and then he's got an IV. They gave him pain medicine, and lo and behold, I get the patient in the aircraft, and the IV 0.9 is a block of ice. I'm pounding it down on the ground and everything. So again, what I should have done in the scene is just get him to a warm environment. There's nothing I can do for that patient. In that environment, I should have just got him in. So, but you live and learn. You don't think about your environment. Like I said, when you're a nurse and working in a hospital, you don't really think about the weather outside. But you definitely got to consider that. Last question, guys. I guess we're looking at it. How long are you in orientation? Orientation is set to how comfortable you are working in this environment. If you got some transport experience or worked at another company, your orientation is about 6 to 8 weeks. If you're coming in like me, I did not have a lot of transport experience. Mine was 12 weeks. And it really is trying to get you to be autonomous. What I mean by autonomous is just basically making decisions on your own and following the protocols coming in. It's hard, guys. It's, you do rely a lot on when you're working in a hospital on other people coming in, and you just don't have it. It's you and a paramedic transporting a patient either by ground or by air. And you have to feel pretty comfortable what you're doing, coming in, and just like, if I can't get them intubated, I can't run out and ask somebody else to do it. It's either you or the paramedic. So, and it's a lot of fun though. I will tell you, I highly, highly, highly recommend it. Pretty cool. Any other questions, guys? Anything? Well, great. Good luck in your career. I hope this was helpful. Again, tell us a little bit about MedFlight and what we do and how we do it. Like I said, sometimes you get a lot of questions on that. Good luck. The one thing I will tell you is, you guys, before you get off, make sure you research heavily what you guys want to do in terms of your nursing profession. I can't emphasize enough. A lot of people get into things that I don't think they really knew what it's about, just because they thought it was cool. And again, and this is a job. This is a job. You're not getting paid to stay home. I'm looking for that job. I want a job where I don't have to do anything and get paid. Until I have that, this is a job. There's requirements you have to do and everything. So again, like I said, highly make sure you know what you're getting into. Ask the people that are in that field, either be OB, peds, ER, ICU, whatever, the perks of it, and then kind of go with that and stuff. I don't think enough people do that. And again, I will tell you the same thing with MedFlight. A lot of people think, oh, it's so cool to work at MedFlight, but research it and make sure you do the things you need to do. Talk to the crews and do an observation day. Again, it may not be something you're interested in. It sounds cool, but it may not be something you're interested in. Or a lot of other people, most people, oh yeah, this is really cool, and I've confirmed it. This is what I want to do. So please, if you have any questions, more questions online, www.medflight.com. I'm the only Steve here at MedFlight. You can track me down on our website. You can go through Haley if you want. Again, ask me questions. And if you ever get a chance, our base is at Don Scott Airport, right off 161. I would love for you to come out and see it. Like I said, I can show you the aircraft and show you everything. Kind of gives you a better representation of what it's like. So good luck, guys.
Thank you, Steve. Thanks. A lot of great information.
Anything else? Can you think of anything else, Haley?
No, I think that was good. Just think everyone really liked it, so we appreciate you taking your time to come talk to us.
Anytime, guys. Like I said, please, if I can do anything else, let me know. Good luck in your careers.
All right, thank you.
It's a good profession.